Hello, hi, I'm on webinar now. Right now, हाँ. आप बस मैं अभी स्काइप आईडी, हमारी स्काइप आईडी है क्या? स्काइप आईडी है क्या? बना दी है आपने? वो बनानी पड़ेगी, बना के मैं भेजूंगा. ठीक है, ठीक है, बना के दे देंगे आपको. ठीक है, वेबिनार की मेल कर दो, आके बना दो. लगाने की जरूरत पड़ेगी मुझे नहीं लगता. पूछता हूँ एक बार. देख लो सर. सर मेरी आवाज आ रही है आपको वहाँ? तो आपकी आवाज नहीं आ रही है मुझे. आपका वॉइस, आपका म्यूट किया हुआ है क्या सारा स्पीकर?
ऑन किया, अभी ऑन किया.
हेलो, तो हियर योर वॉइस एक बार देखता हूँ. आ रही है आवाज?
हेलो
बोलिए सर.
हेलो हेलो.
नहीं आ रही ना मुझे, आप लोगों की आवाज नहीं आ रही सर.
हेलो
हेलो, हाँ, आप लोगों की आवाज नहीं आ रही.
किसकी नहीं, किसको आवाज नहीं आ रही?
ट्राई करता हूँ सर.
ओके,
ऑन किया है?
Everything is on.
एवरीथिंग इज ऑन. यार ये स्पीक नहीं लगा है. या
नहीं, आपको अनम्यूट करना है. नाउ इट्स फाइन. अब नाउ इट्स फाइन.
Check my speaker. Your speaker is not working properly. Your voice can still be recorded, but the voice of the other participants cannot be. Check my speaker. Continue record. Check.
Can you hear my voice?
Recording लिखी हुई.
Recording तो on करो, off करो, that doesn't matter. लीजिए. कहाँ गया? Stop. अभी भी नहीं सुन रही वो पहले.
Good evening to all distinguished colleagues. I'm Dr. Samir Muchala, heading the medical affairs for cardiology and diabetology.
Sir, audible नहीं है आवाज.
At Zydus Healthcare Limited. I'm sure at the outset, you and your loved ones are safe and healthy during this trying times. It gives us immense pleasure to invite each one of you today to this panel discussion on diabetes and COVID-19. We all know that the IDF has certified as recent as 2019 that we have 77 million diabetic patients in India. Also, we are currently reeling under the global epidemic of COVID-19. To add to our worries, those patients with diabetes are at worst outcomes with respect to its complications if they contract COVID-19. To enlighten us more on this close link between diabetes and COVID-19, we have an elite panel with us. It gives me great pleasure in introducing our moderator for the evening, Dr. Surendra K. Sharma. He's a consultant endocrinologist at the Diabetes, Thyroid and Endocrine Clinic at Jaipur. He's delivered more than 350 lectures.
क्लिक कर रहे हैं उसमें fail to detect your speaker. मेरा speaker नहीं detect कर रहा है ये.
Jignesh bhai, can you just help out Dr. Sushil? Mr. Jignesh. He's the organizing secretary of the 3rd National Conference of Diabetes Food Society of India. He's the joint organizing secretary of RSSDI in 2003. He's the member of various elite bodies like API, RSSDI, ADA, AACE, Endocrine Society of India, Endocrine Society of USA, and the Indian Society of Bone Mineral Research. I welcome Dr. Surendra K. Sharma and request him to take the scientific proceedings ahead and introduce our esteemed panelists, Dr. Ajmani, Dr. Anuj Maheshwari, and Dr. Sushil Kotru. Over to you, Dr. S.K. Sharma.
Thank you, Dr. Samir. Thank you very much. Good afternoon, dear friends. This is a difficult scenario, difficult time. I hope everybody, you and your family are healthy, and let's have so many, you can say, people are now joined us. So let's start our proceedings. Before that, we have a distinguished panel of you can say, panelists here with us. So first is Dr. A.K. Ajmani, who is a DM Endocrinology from PGI Chandigarh. He was senior to me at PGI Chandigarh, and he was previously head of department of RML Hospital, New Delhi. He has great publications, more than 40, and he has written many chapters in the books, and he is a recognized teacher. Even he taught me while we were in PGI Chandigarh, and he is DM examiner also. Our next panelist is no other than Dr. Anuj Maheshwari. You all know him. He is every day he is coming to webinar and teaching us something or other. Dr. Anuj is professor and head in medicine, University BBD University Lucknow. He has done PhD and DNB teacher and guide for the last 5 years. He has large number of papers, more than 45, presented in international and national forum, including 2 in ACE, Orlando, and ADA 16. He has 34 publications on diabetes and its complications. He is reviewer of Elsewhere Journal of Diabetes and its complications. He is nominated for BC Bansal Oration in annual conference of ISCM, and he is recipient of 216 Notable Achievement Award in Hypertension Prevention and Control at the population level by World Health League, and he is founder chapter secretary of RSSDI UP chapter. He is a very active person in RSSDI circle, and he has also organized DIPSI in 2017. Our next speaker is, panelist is Dr. Sushil Kotru. He is MD Medicine and Fellow of Endocrinology and Diabetes. He is consultant and head at MEX Endocrine Diabetes and Obesity Care Center at Bhatinda. His PG Diploma in Endocrinology from University of South Wales, UK. Masters in Endocrinology, University of South Wales, UK. fellowship in diabetes management, CMC Vellore, and he's member of so many distinguished societies, and he's recipients of large number of awards right from RSSDI, and he's received award from World Health Diabetes Congress, and vast clinical experience spanning around 15 years, and regular invitee faculty at the key conferences. We know him as a small bearded person, but the COVID epidemic has increased the size of his beard now, and he's looking very smart with a more thicker beard, dear friends. So with this, we can start with our uh, panel discussion. As we all know, it is a COVID pandemic era, and we are having difficulty in approaching our patients. So large number of our patients are on, you can say, telemedicine or on phone or on a WhatsApp group. And during that time, we have our duty of highlighting many of these aspects of diabetes and COVID epidemic. So Dr. Ajmani, my first question goes to you. As we all know that there are more proneness for developing this COVID infection in some of the group of patients, like we also, I'll say, elderly patients, people with diabetes, cardiovascular disease, hypertension, or chronic respiratory disease. So what is your answer to that, whether diabetic patients are more prone for development of COVID infection? Over to you, Dr. Ajmani.
Thank you, Dr. Sharma. So before answering that why diabetics are more prone to contract COVID-19 infection, first we have to answer whether we agree that all our diabetic are more prone to contract COVID-19 infection. There are many people, there are ADA guidelines which suggest that patients who are young diabetic, very well controlled, not having any of the diabetic related complications, they are probably not more prone to contract the infection. However, once they contract the infection, diabetic, especially long duration diabetes, especially uncontrolled diabetic, especially those with further complications such as CVD, kidney complication, they are more likely to have severe complication of COVID-19 and may also result in greater number of fatalities also. Why they contract infection more often in patients who are uncontrolled or otherwise type 1 diabetics? Probably they have a defective innate immunity. By that we mean that in terms of neutrophil action, chemotaxis, phagocytosis, and cell-mediated immunity, all of them are impaired. And also probably diabetic otherwise are having a sort of pro-inflammatory state. I mean, the cytokine storm occurs. They are the one, especially one who have complication, who will go into requiring the serious complication of COVID-19, requiring ICU care, and going for a greater number of fatalities from COVID-19.
Thank you, Dr. Ajmani. As I understand, you are saying that people who are well-controlled diabetics may not be having more proneness for the infection, but once they are uncontrolled, they may have more proneness.
Definitely.
But you are highlighting that their chances of poor prognosis and poor outcome are there if they are diabetic once they develop this infection.
Right,
So
right, right.
with that, we may go to Dr. Anuj Maheshwari. Dr. Maheshwari, as diabetes is a common comorbidity with other cardiovascular risk factors like hypertension, CSD. What would be the ideal goal with reference to blood pressure, cholesterol level, and HbA1c when we say that patients are well controlled also?
Right, sir. As far as we know that this COVID-19 virus, which is the SARS-CoV-2, it enters into the respiratory epithelium through the ACE2 receptors. So many of the times it has been arisen as a controversy whether particular medicines should be given or not. As far as HbA1c target is concerned, of course, the HbA1c target should be the 6.5 or 7 if the person is elderly. As far as the blood pressure target is concerned, 130/80 is the unanimous target. May the person is diabetic or non-diabetic. It has been declared by American College of the Cardiology as well as the International Society of Hypertension to keep your patient less than 130/80. Goal should be 130/80, as well as the cutoff to start treatment, that is also 130/80. So this is clear in that way. As far as treatment options are concerned in the hypertension, as many of us were a little bit worried about the use of the ACE inhibitors in early days of the COVID-19, because of the reason that this virus was entering to the respiratory epithelium through the ACE2 receptor. So many of our colleagues were having an idea that if we shall inhibit the ACE1, then probably the ACE2 will be more active and then virus will get easy access into the respiratory epithelium. Actually, a study which has recently been published on 24th April in the Journal of the American College of the Cardiology, this has been done by the Chinese people, those who has treated the COVID-19 patient in its early days. And as per this study, they have reached to the conclusion, even the patient, those who were developed hypertension during their intensive care unit or as an inpatient, they have also got initiated for antihypertensive therapy on the ACE inhibitors, and the mortality was much lesser than those patients in which some other options other than the ACE inhibitors or ARB has been opted. So ACE inhibitors and ARB actually reduces the mortality even in the COVID-19 also. As far as the out of COVID-19, it is very well established already that this is a very good antihypertensive medication to start with. And in COVID-19, we can also go with these medications without any difficulty.
Thank you, Dr. Maheshwari. We can take this question further to Dr. Sushil. Dr. Sushil, as we all know, there was great controversy going on regarding the ACE2 and angiotensin receptor blockers or ACE blockers. So what is your thought about this thing? Whether we can use ACE inhibitors or ARBs in our patients while they are having current COVID-19 infection?
Good evening to all of you, sir. There was some technical snag going on. Sir, there are two theories as such presently. One theory shows that because the receptors, because the entry of cells that happens through these receptors, and if there is hyperglycemia, the entry of these receptors, I'm talking about acute hyperglycemia, so it can increase the entry of virus into the cells, into the beta cells also, and can lead to all the complications. But at the same time, we know ACE inhibitors have a very important role. It might help in decreasing the pulmonary edema also in some patients, lung injury also. So two theories at the same time, one beneficial, one negative theory at the same time. So the AHA, the European College of Cardiology, all these have right now given the hypothesis. The most important thing is that we should continue with the same treatment, looking at the positive impact it has on cardiovascular morbidity and mortality in all the diabetic patients. And we should not discontinue the treatment part if the patients are on ACE inhibitors or ARBs.
Thank you. So the answer to this question is that at present, most of the big societies and bodies are telling us that if the patient is on ACE or ARBs, we should not stop them because they may have more problem if they stop ACE inhibitors or ARBs. Thank you. So Dr. Anjumani, the next question is a controversy. As we all know that we are using SGLT2 inhibitors in large number of our otherwise usual diabetic patients for the management, as well as we know that now there are benefits seen in cardiovascular outcome once the patient is on SGLT2 inhibitors. So whether we can continue to use these SGLT2 inhibitors when the patient is having COVID-19 infection, or there are concerns like volume contraction, dehydration, and acidosis when we are using SGLT2 inhibitors. And so what is your answer to this?
Dr. Sharma, patients who are not on SGLT2 inhibitor, at least I will not be starting SGLT2 inhibitor while they contract COVID-19. Having said that, patients who are already on SGLT2 inhibitor and now have COVID-19 infection, if it is a mild disease, as we know in many of the patients, it's a very, very mild disease. Patient continues to have his meal, properly, can maintain his hydration. In such patient, probably this SGLT2 inhibitor can be continued. Thirdly, we come to the patient who are type 1 diabetic and sometimes we are using off-label SGLT2 inhibitor. Probably we should stop them because this drug leads to increase in the incidence of diabetic ketoacidosis. Patients who have a moderate or severe illness where we are not sure about the food intake and whether patient has the capacity to maintain his hydration status, then the risk of hypoglycemia, risk of dehydration, acute kidney injury comes up. Probably in these class of patients who are more serious, that we should stop SGLT2 inhibitors. But otherwise, patients who are asymptomatic or patients who have mild diabetes, they should be continued on SGLT2 inhibitors. Anybody who has more than mild disease, where we are fear of dehydration, where we have, and because of sickness, there is also increased incidence of diabetic ketoacidosis. In such patients, we should be stopping SGLT2 inhibitor and going on to insulin. Already, if they are patient on insulin, then monitor more frequently and adjust. If not on insulin, then we start insulin.
Can I have some tell some lines about that also? So can I interrupt in between, sir?
Yeah, please.
With your permission.
Yeah.
Patients of type 1 diabetes taking off the label SGLT2 inhibitors, even though they might be having some mild COVID-19 infection, still we have to stop SGLT2 inhibitors in this class of patients. And those patients who are hospitalized, we have to stop SGLT2 inhibitors. Even though they might be having mild COVID-19 infection, if they are hospitalized, we have to stop these drugs. And can anybody throw light on DEAR-19 trial? They are talking about dapagliflozin in this class of patients. Sir, you want to say something about that DEAR-19 trial study?
AstraZeneca has started a trial by the name of DARE-19. As the name suggests, a daring attempt, because till date we were thinking that SGLT2 inhibitor should not be given to very sick patients. We usually withdraw them thinking that it may cause more dehydration and may lead to more of this acidosis. But on other hand, they say that there are many positive aspects of SGLT2, because as the DAPA heart failure study is telling us that they are helpful. And similarly, in COVID-19 infection, we see that cardiovascular, you can say, damage is significant. People are developing myocarditis, acute coronary syndrome, and arrhythmias and congestive heart failure. So looking at that aspect, as well as they do have some inhibition of many of these factors like sodium hydrogen, you can say, receptors there, as well as RPL receptors. So those receptors are inhibited by GLP-1, SGLT2 inhibitors. So that's why they say that let's look at these patients when you are giving SGLT2 inhibitors. So let's wait for the trial results. It may come after a few months. So by that time, as you rightly highlighted, Dr. Ajmani highlighted, those patients who are well controlled and developing this infection, we can continue. But he was very cautious that during infection, we should be avoiding the introduction of this drug at the time when they are admitted. And with that, we can go for the next question to Dr. Anuj. Are the risk of this contracting COVID-19 similar in our type 1 and type 2 diabetic patient? Because they are having different, you can say, type of presentation, young age. On other hand, we have middle age or elderly, and those who are on only insulin, and then those who are on either oral drugs or a mixture of oral plus insulin. So whether the infection is similar in these two group of patients.
Yes, sir. There is no head-to-head study has been done with the COVID-19 in itself, comparing the type 1 and type 2. What the informations we have, that is for the infections. As far as the type 1 diabetes is concerned, this is also associated with the compromised immunity, innate immunity, cellular immunity, humoral immunity, if it is persisting for many past years. The same thing happens in the type 2 diabetes also. In type 2 diabetes, there is an additional problem, that is the insulin resistance. So insulin resistance is also there. and that also causes the additional difficulties related to the COVID-19, as Dr. Kotru has said, that because of the glucose toxicity, high amount of the glucose, there is a easy going into the respiratory epithelium, and virus enters there. Multiplication of the microorganisms is also faster, but it happens in the type 1 diabetes also. The difference is that type 1 diabetes is mostly treated, or almost all the time treated, by the insulin. So we can always increase the dose of the insulin and get the control earliest, as and when we see that control is not good. As far as the type 2 diabetes is concerned, if patient is already on the oral drugs, then the challenges comes, as Dr. Ajmani said, that SGLT2 inhibitor is there. We need to keep our patients hydrated. A problem is there, if we withdraw the SGLT2 inhibitor and add another drug, probably it will take another few days and patient will remain uncontrolled for some time. Even if we add insulin, then again the same problem will occur. So better to keep on these patients in the hydration better and continue with the medication, or we switch over to them insulin. We all know that always it is good to start or keep on the patient on insulin if the severe infection is there. So I think, in my personal opinion, type 2 diabetes management little bit more challenging in the COVID-19 patient, because it has got multiple aspects to take care instead of type 1 diabetes, although both are having its own dreaded outcomes, which are known all of to us.
So I differ to some extent in type 1 diabetes because they are prone to diabetic ketoacidosis. And we have to monitor their ketones also, urine ketones. They are prone to diabetic ketoacidosis. The monitoring might have to be done 4 times, 5 times, or 6 times a day. And at the same time, they might require correctional doses also. Carb counting is very important. Hydration is also important. Type 2 diabetes being elderly population, they are prone to the serious complications of COVID-19 infection. In comparison to type 1, they will be much more younger population. The chances of serious complications of COVID-19 might be lesser in comparison to type 2 diabetes population. So you can add to that.
Thank you. People's experience is that sometimes their diabetic profile deteriorates very significantly, and they may require very large doses of insulin, whether they are type 1 or type 2. There are some, you can say, reports which says that this infection is directly causing damage to even beta cells. So there is a destruction of beta cells also because of this coronavirus. So many times, as both of you rightly highlighted, that they do cause significant increase in hyperglycemia. And as both of you are saying that they usually require insulin dose initiation or intensification. And of course, type 1 or type 2 both require looking at ketosis also. Thank you very much. So we can go to the next question for Dr. Ajmani, for Dr. Kotru, and that is, what is your opinion about whether metformin in these patients who are developing COVID-19? So what are the precautions or your idea about to continue metformin in these patients or not?
So as all of us know, if these patients are critically sick and they are getting admitted in the hospital, the chances of acidosis is very high because they might be suffering from multi-organ dysfunction. They are suffering from some respiratory insufficiency, and they will be suffering from hypoxia, and metformin can cause lactic acidosis in these patients. If they have some sort of renal involvement also, so the chances of acidosis will be much, much higher. We have to monitor their kidney functions also, and we have to monitor their ABGs also. In a patient who is having mild symptoms, already Dr. Ajmani was talking about these patients having mild symptoms, staying at home, we can continue with metformin. But those patients who are hospitalized, we should stop metformin in this class of patients. Monitoring KFT, LFT, and monitoring for their acidosis is very important. We should stop metformin. And we might have to go for some sort of intervention also, some sort of investigation using a contrast agent also. It can cause renal injury also. So we have to stop metformin in this class of patients if hospitalized.
Absolutely. So as you rightly highlighted, infection is mild in more than 80% of patients. Only 15% of patients are having slightly more severe or moderate infection, and 5% of them require intensive care. So those patients who are well controlled and having mild symptom, they can be managed with metformin with all the cares you highlighted. Dr. Ajmani, is the diabetic patient with COVID-19 are at a higher risk of developing hypoglycemia. So we were discussing hyperglycemia, but whether there is any, you can say, increased risk of hypo also there.
Well, whenever a patient has a concurrent illness, especially a severe illness, most of the times we are worried about hyperglycemia and ketoacidosis. But sometimes when the patient has a very severe sepsis, then we know hyperglycemia can occur. Also, when the patient is sick, patient's intake of food also decreases. And if we have not made accordingly changes in our treatment regimen, especially the patient who are on insulin or sulfonylureas, they can develop hypoglycemia. And there could be another aspect to this, that patients initially at least were being advised to take chloroquine or hydroxychloroquine also. And we know that can also lead to hypoglycemia. So these are some of the situations in which there can be hypoglycemia when there is a mismatch between the intake and our therapy.
Thank you. As you rightly highlighted, there is we should be looking at both the hyper as well as hypo, and monitoring, frequent monitoring is required to tackle this hyper and hypo problem. Dr. Anuj, there are some reports that DPP-4 inhibitors may be having some beneficial effect in these patients. So what is your idea about DPP-4 inhibitors during this COVID-19 infection?
What I feel that if the patient is having the severe infection, hospitalized, then nothing is better than insulin to treat hyperglycemia. In the patient, those who are outside of the hospital, and especially the patient, those who are on the high risk of getting COVID-19, or those who are in the outside day-to-day life, they, in all of those patients, the DPP-4 inhibitor seems to be the most benign option as compared to the other drug, because SGLT2 inhibitor is its own risk of the dehydration and ketoacidosis. Similarly, the metformin is having the risk of the lactic acidosis, and of course, the sulfonylurea is having the risk of the hypoglycemia. But there is no such kind of the risk with the DPP-4 inhibitors. So I prefer to keep our patient on a DPP-4 inhibitor instead of any other drug if it is to be started. But again, I would like to say, if a patient is going on control, well control on any medication, then it would be really detrimental to keep him away from the existing medication and put on the new medication, because it will take further 3-4 days to get under control. So better is, if such kinds of the situation arise, then we should take our patient on the insulin. Probably it may give us the control in overnight or the next 24 hours.
Thank you. Very good message, that those patients who are mildly having mild infection, or you can say mild symptomatology, then can be managed with their existing drug if they are well controlled. And those patients who are in hospital, they mainly require insulin. Very good. So
can I add, sir, one or two lines about that? Some unique features about DPP-4 inhibitors, sir. Sir, DPP-4 inhibitors, DPP-4 receptors as such, the MERS coronavirus, the receptors for their entry was DPP-4. So recently there are some studies they have shown that might be that COVID-19, the portal of entry can be these receptors also. So if we use DPP-4 inhibitors, might be we can block some of the entry to the virus also. And DPP-4 receptors, they increase inflammation. We know about the pro-inflammation in this during this COVID-19 infection and the cytokine storm. So DPP-4 inhibitors, in addition to glycemic control, might have some extra benefits also while using in these class of patients. So what do you have some?
Still juries are not out yet about the benefits and harmful effect of DP4, but these are some, you can say, theoretical aspects. So we will keep a watch on what happens in next, because this disease is a new disease and it is evolving. We got very little information from China, where the large number of patients were involved earlier. But now, after Italy and after USA and UK involvement, and now we are getting real good, you can say, scientific material regarding this disease, and we are getting wiser and wiser every day. But it is a evolving scenario, and that's why we can't say at present that what is good and what is bad for our patients regarding this. Some of these ideas like DPP4 or ACE inhibitors, etc. So,
are you
Doctor,
doing some research work at SMA Jaipur also, sir?
Not you can't say research, but they have started doing admitting these patients earlier, and then they started using multiple antiviral drugs which we were using in AIDS, HIV infection. And then now yesterday only they have started using convalescent plasma to few of the patients. So they are treating their patients nicely and providing us information. So Dr. Ajmani, next question goes to you. Uh, what are the precautions we should be keeping in mind while there are elderly patients who are developing this COVID-19 infection? Because this is a high risk group.
Dr. Sharma, as you have just said, elderly are the one, if they are infected, they have the highest fatalities. So even in India, whatever little data we have seen, that about 15 to 20% of the patients are elderly, but 50% of the mortality is among the patients who are more than 60 years. So elderly, we have to protect them. We have to put them in strict isolation. They should be treated like they have to be, every other person is already infected. So this using of distance, social distance, using a sanitizer, using hand washing, it has to be particularly important for the care of elderly. And we should uh, probably isolate them, give them a separate room, give them a separate toilet, so that their interaction with other people is kept to minimum. So in the elderly, first thing is to prevent them from having a infection. If they do have infection, it is going to be very difficult for them. They are more prone to hydration, more dehydration, more prone to having a kidney complications. And then we have to take care of them in terms of the medicine that we have to use. We have to monitor them more frequently. Probably many of them will require insulin once the control goes haywire. So probably most important thing would be prevention of such infection. And then if it does happen, then we have to treat it accordingly as we do in other patients.
Thank you. So Dr. Maheshwari, next question goes to you. Under the present COVID-19 scenario, would hydroxychloroquine, as we discussed it day in, day out, right from the beginning of this COVID pandemic, which is also, hydroxychloroquine is also approved as an anti-diabetic drug, third line anti-diabetic drug in our diabetic patients. So what are your concern about this drug when the patient is having COVID-19 infection?
I think there is no need of the concern. In fact, it is beneficial. Especially in the condition if the patient is having the COVID-19 and he is already taking the hydroxychloroquine before for the diabetes control, his prophylaxis is already going on. So this will help him to avoid the COVID-19 infection, and this is the biggest benefit of a patient. Of course, even if you want to start in a new patient, still it is not contraindicated. You can very well start with, as far as any anti-glycemic drug would be given, then risk of the hypoglycemia would be there. So with the say that much of the risk, we can go ahead with this also. There has been reports that it may have some cardiovascular problems, or it may have some prolongation of the this QT interval. These kinds of the problem we have not seen in our diabetic patient when we have given it for the routine diabetes care. So in 400 milligram in a day, we did not find these kinds of the issues. So in this much of the doses, we need not to worry for that.
Thank you. Hydroxychloroquine has got too many controversies, but one thing which was good was that India was in forefront of sending hydroxychloroquine to more than 123 countries, including USA. So
Yes,
India has gained some, you can say, good image by this drug. So with that, I go to the next to Dr. Sushil. Would insulin be considered as a superior alternative in people with type 2 diabetes mellitus having poor glycemic control?
Those patients who are admitted in hospital.
Are you not
and
able
those
to
patients
listen to me?
Hello? Sir, you are audible, sir? You are audible. Am I audible to
Is
you,
there
sir?
any
Yes,
problem
yes, you
there?
are audible.
I
Keep
am
on,
audible.
keep on speaking.
Yeah.
Sir, those patients who are admitted in hospital, insulin is the best possible treatment what we can provide to them. But those patients who are stable patients, and 80% of those patients who are suffering from COVID and are either having mild symptoms or asymptomatic, they can continue on oral antidiabetic drugs. But if they have uncontrolled diabetes, insulin is the best possible treatment, because insulin has shown better prognosis in these patients who are suffering from COVID-19 patients, because it has shown that it decreases the transmission of, it decreases the entry of virus into the cells also, and better glycemic
There's some
control.
audio problem. Dr. Samir, can you look at this?
Yes, sir.
I will
Better glycemic
consider
control,
the
better
technical team right
prognosis.
away.
Yes, sir. Am I audible to you? Better glycemic control, lesser morbidity, lesser mortality. So we know insulin is the best possible alternative what we have in COVID-19 patients having uncontrolled diabetes.
Yes, even if the patient is outside of the ICU, outside of the hospital, insulin in every condition is the best option to treat the hyperglycemia.
Type 1
Yes,
diabetes, we know he requires patient requires insulin. Patient on stable on oral antidiabetic drugs does not require insulin. Only those patients, if they are having uncontrolled diabetes, mostly immunocompromised elderly patients, uncontrolled diabetes patients, we know if they have uncontrolled diabetes, the chances of acquiring infection is much, much higher. The chances of complications, the severity of COVID-19 infection will be much, much higher. So good glycemic control in these class of patients is the main option what we have to prevent serious COVID-19 infection. Even though they might not be having the infection, if they have infection, good glycemic control will prevent the serious complications of COVID-19 infection. So in addition to oral antidiabetic drugs, we can add on insulin to have the best possible glycemic control. This was basically a broad question, not a specific question. So
there is some audio problem, I think. Can you hear me? Yeah.
Sir, we can hear you. But
We can hear you.
So,
Dr. Sharma, we can't hear you.
No, can't hear.
Dear friends, as we all know that whenever a diabetic patient is developing severe infection, whether it is COVID or any other, the dictum is that we stop most of the oral antidiabetic drug and we start giving insulin therapy, and that is to intensified insulin therapy. If the patient is eating, then it is usually basal bolus therapy. If the patient is very sick and not eating, we usually give insulin infusion in the ICU setting. So with that, next question goes to Dr. Ajmani. Should insulin be, what is the reason for frequent cases of severe diabetic ketoacidosis in patients who are COVID-19 infection? So as we already highlighted, many of these patients are developing severe hyperglycemia and diabetic ketoacidosis. What's your opinion?
Okay. When there is a severe medical illness or any severe stress, all diabetics are prone to develop severe hyperglycemia and acute hyperglycemic crisis. With COVID-19, we have been seeing it more often than what we see otherwise. And there are two aspects to this. One, that the ACE2 protein is present on the pancreatic beta cell as well. So COVID-19 can probably directly damage the beta cells and reduce the production of insulin, leading to diabetic ketoacidosis. Secondly, even the insulin resistance, which we see during sepsis, is out of proportion in patients who have COVID-19 infection. These are the two probably reason that patients with COVID-19 have out of proportion hyperglycemia and increased incidence of diabetic ketoacidosis compared to any previous infection that leads to such condition like severe illness.
Thank you. Recently, in USA, a large number of obese young people, particularly the Black community, developed severe COVID infection as well as poor prognosis. So, Dr. Maheshwari, what is the reason of frequent cases of severe, what are the challenges faced in treatment of obese diabetic patients infected with COVID-19?
As we have discussed many of the times in this panel discussion, the biggest reason and biggest hurdle or obstacle, what you can say, for the management of diabetes, hypertension, obesity is the insulin resistance. And when it is in association with any infection, may it be COVID-19 or any other viral or bacterial infection, then it again becomes a challenge to handle it. And most of the time insulin is required to handle the infection, but again we know that insulin is having its weight gaining potential. Again, the insulin is having its water retention potential, and in obesity again we have to face the problem that we should not allow to weight gain in those patients. Apart from that, drug dosages is again an issue. In obese patient, we need to find the drug dosages as per their body weight, and probably most of the time the drugs which are available in the market, they are in the fixed dose, or many of the times they are in the set dosing format. Then we need to give them the actual dose. Most of the clinicians may not be finding or may not be able to do that as per the requirement of those patients as per their weight. Probably these are the bigger challenges to handle the obese patient for any infectious diseases, not only for the COVID-19 only.
Thank you. Dr. Sushil, there is a question for you that how would you balance risk and benefits of metabolic surgery in diabetics with obesity in this COVID period?
I feel that metabolic surgery, we are talking about bariatric surgery, it's an elective surgery. So in a sort of this scenario of COVID-19 pandemic, we should overweigh the positives and negatives of doing a bariatric surgery in a patient with the COVID-19 pandemic. I don't feel this is the option right now. It is better to optimize the glycemic control, optimize the lifestyle interventions, and treat cardiovascular risk factors. And later on, once this pandemic is under control, then we can plan for bariatric surgery later on. I don't feel going for an elective surgery. We know the risks of going for this surgery, and if the once we are going for this surgery, doing a laparoscopic procedure, it will generate aerosols and can infect healthcare professionals also, healthcare persons also. So this is a risky procedure right now with this COVID-19 pandemic. Keeping the generating risk for the healthcare professionals. I don't feel this is a procedure which should be done right now during this pandemic. So it can be done later on. Right now, we should treat the cardiovascular risk factors, treat the diabetes, control the glycemic parameters. This is the much better option right now.
Thank you. Dr. Ajmani, large number of our patients are not able to reach to us because of this, you can say, lockdown. And people are inquiring from us about their disease and their problem on phone. So now people are arguing whether what are the ethical and medico-legal issues related to the use of telemedicine in glycemic control in current scenario.
Well, that is very true. Now the patients are very reluctant to visit the clinic, and sometimes even that some doctors are not even opening the clinics. So it is the role of telemedicine has come up in a very big way, and Indian Medical Council, the Board of Governors, have given a lengthy guidelines that telemedicine is acceptable, it is very legal, and they have given a flow chart also, especially patients who are for the first time. Probably we should do a video consultation. For follow-up patient, we can do a audio consultation. However, we have to remind that there are certain assets that you have to identify the patient correctly. You have to ask for more information, whatever you need to treat this patient at any point of time. Right in the beginning, if you think the patient needs emergency care, he should be referred. And during the course of this telephonic consultation, if you think that you can't treat this patient just by on telephone, you have to inform him that you need to be seen personally. Having said that, if all these issues are sorted out, most of the our patients, a thyroid patient, a stable patient, they can be given a prescription on the by means of telemedicine. However, you are liable to all professional professional actions such as medical negligence. Patient can report to you MCI. Patient can go for a consumer action. So whatever in-person consultation has the liability, you are supposed to have that liability even when you're doing a telemedicine. And regarding the ethical issue, you have to always maintain the confidentiality and the privacy of the patient you are seeing, because if you're doing a video consultation, it even becomes more important. And you have to keep the records for many years, about 5 to 10 years, you have to keep those records of the consultation.
So thank you, Dr. Ajmani. As you rightly highlighted, that this is a time where telemedicine may be going up, and we have to keep some precautions, particularly if the patient is having follow-up. They say if the patient is already treated by you and he is consulting you again within a period of 6 months, then it is a follow-up. If it is consulting after 6 months, it is a new patient. Secondly, it is always good to have a video, you can say, consultation. Patient should be contacting us, then it is implied that he has given a consent to us. Otherwise, we have to take a consent also. Then it is important to have a small history and some investigation if available, and then we should be giving a tele consultation. And as you rightly highlighted, we will be keeping this, preserving these documents for a long time, and confidentiality of the documents is also very important. Thank you. Dr.
Here I would
Maheshwari,
like to add.
yeah, please.
Here I would like to add one thing. If you are coming across a patient who is first time consulting you, you can suggest only, you can prescribe only the OTC drugs to him. And only the drugs of the category B and drugs which are in the other list A can be given if the patient is of your follow-up patient, and follow the patient shall be prescribed here. And it is very much important. And video calling is necessary for the list B and list A drugs to be prescribed.
Absolutely, you are absolutely
What
right.
about insulins? If you want to start insulins, then
Yes, video calling is must. Video calling is must, and you have to be, and he has to be your follow-up patient.
Yeah.
For new patient.
Yeah.
Type 1 diabetes, insulin, want to start insulin, we need physical consultation of the patient.
You need to take the consent from him. If the call is coming from him, then the consent is not required, as Dr. Sharma has already told it to us. But if we think that patient needs insulin, then we should tell him to find a nearby hospital, because there he can very well be monitored with the SMBD and all these things. And if he's already prescribed insulin by you or by some other physician, you can definitely suggest him the modification of the doses.
Absolutely right. But there is a general, you can say, term there that injectables should be avoided in telemedicine. But if the patient is already on follow-up, we can increase or decrease the doses. But people are taking help of these videos, educational videos, where we are telling them about how to take insulin, what are hypoglycemia, and how to titrate the doses. Those things are there. But there are many gray areas we don't know. But whatever we are doing for the benefit of the patient. But we should be very careful about acute emergencies, and first time consultation, it should be by a doctor, personal, you can say, doctor to patient visit should be there. So with that telemedicine part, Dr. Maheshwari, influenza and pneumonia vaccination may decrease chances of secondary bacterial pneumonia after the respiratory viral infection. However, it is also true for a viral epidemic like COVID-19. What's your opinion?
As far as the diabetes is concerned, because our today's panel discussion is in relation to the diabetes and COVID-19, even if the COVID-19 is not there for every diabetic, we recommend that influenza vaccine and pneumococcal vaccine should be given. So if we are having a high risk for any respiratory infection or any infection which is entering through the respiratory epithelium, it is always good to take care of these two things. One is the influenza, another is the pneumococcal vaccine, because these two are the most common and you can say the most prevalent respiratory infections in our society. So they may take the secondary place if our patient's diabetes is not so good control, or COVID-19 has entered and it has reduced the immunity, then secondary infection of these things may occur in the same way as it happens with the pulmonary tuberculosis as a secondary infection.
So very rightly said by you that most of our patients should be having these vaccines, but particularly if you segregate, then elderly patients, those who are suffering from chronic respiratory diseases, or those who are having very poor immunological aspects, we should be providing this benefit to them.
Unknown caller.
Dr. Sushil Kotru, the next question goes to you. Is there any evidence of deleterious effect of coronavirus on the beta cells, which can affect the long-term prognosis in our diabetic patients?
As already Dr. Ajamani said, there are ACE2 receptors on beta cells, and once there is entry of this virus into the beta cells, it can lead to death of beta cells, as has been shown in animal models, not in human models still. And it can lead to insulin deficiency in these patients. And it has been shown in patients which were admitted in Italy, also in China also. These patients came with diabetic ketoacidosis also, and some patients who were admitted in hospital, they required higher doses of insulin in contrast to other critically sick patients. And the doses were very high if we compare with other critically sick patients who are non-COVID patients. So they lead to damage to the beta cells and long-term severe insulin deficiency. We need long-term follow-up of these patients.
Thank you. Dr. Ajwani, what precautions should we offer pregnant women with gestational diabetes, keeping COVID-19 infection in mind?
Again, we have to protect them from acquiring infection. That is the most important thing to do. Otherwise, you have to treat the gestational diabetes patient as otherwise you do. And we have been using insulin more often, and sometimes we have been using metformin now for a long time. So any patient who's otherwise stable, and even though asymptomatic or COVID-19 mildly, we can use in those patients also. But main thing would be to protect these ladies.
So all those precautions of prevention should be applied to pregnant lady
Right.
also. And they say that they are not having an increased proneness for this infection. So that is a good point. And then secondly, they say if the patient develops COVID-19, there is not very severe, you can say, infection happening as it is happening in all other population. It is, you can say, prognosis is like that. But just yesterday, there was a case where a newborn was developing a COVID-19 infection. Earlier, it was said that newborn is not going to have infection if the newborn is separated from the mother immediately after the delivery. But they say that when you are having your antenatal checkups of these pregnant ladies, we can reduce the amount of, you can say, ladies coming to hospital for their usual checkup. So they reduce the number of ANC visits, and some of the visits may be on telephone, on video calling, etc. But there are few visits which are essential, like where they go for ultrasound examination, etc. Then of course patient should be there, but patient should be avoiding all those crowded area and should be taking a pre-appointment with the you can say obstetrician, and then going straight and having their examination. Dr. Sami?
Transplacental transfer of virus?
Yeah, please.
Any transplacental transfer of this virus?
Earlier it was said that it is not there, but yesterday just there was a news that one baby just after the delivery, when they examined, the baby was found to be, newborn was found to have COVID-19. Whether it was exposed while during labor or it is a transplacental, it is yet to be decided. But earlier reports are saying that there is no, you can say,
Yes, yes.
transplacental.
Many of reports we have seen, and many of the cases has been reported on TV and other places, that transplacental transmission of the COVID-19, and even COVID-19 is not affecting the intrauterine life. So as some of the virus like this German measles virus affects intrauterine life, it is not affecting any intrauterine adverse effects on the life. So, but maybe that person, that child could have got outside infection from someone, or maybe from mother.
So while they say that while lactation is an important part, so the patient, if the mother is infected, then there is a difficult scenario. But they say that with all the precautions, you can extract the milk from the mother's breast by help of a breast pump, and then you can give that milk to the newborn. That is important. Dr. Samir, do you have any questions or any comments from our audience?
There are a few questions. Overall, the
You can
comments are
ask
very
the
good, that
panelists
they are
from your
enjoying
side.
the discussion.
Yeah,
There are a few questions from the audience,
yeah.
which you can direct to the panelist. The first question is there any deleterious influence of smoking on glycemic control in diabetic patients with COVID-19?
Very important, very good question, and we must have included in our list of the questions. Smoking is not only injurious for the diabetes point of view, but as a respiratory infection, respiratory epithelium is already compromised health in the patients, or especially those who are receiving this COVID-19 infection, may it be elderly or young age patient or any age patient. If he is prone to get the COVID-19 infection, the smoking is definitely adding the problem to that patient. And we know it very well that smoking increases the insulin resistance, and smoking causes the worsening of the diabetes, as well as complications of the diabetes like angiopathy are worsened by the smoking. As also it may be the atherogenic. So a lot of things are there which makes the smoking injurious for a diabetic patient, in addition to the respiratory problems which are with the smoking.
There are so many myths. There are so many myths going on in the public that when you are smoking hot, you can say smoke is going inside, it may be killing the virus. Similarly, people are saying if you are drinking alcohol from outside, you are applying sanitizer. From inside, you should have alcohol. So all these bad myths are going on in public. So we should discourage all these things. Dr. Sushil, you wanted to say something?
Long-term smoker, they might be suffering from COPD, and it will increase the fatality in these patients. So they have to stop smoking. At least it is better never too late, na?
Dr. Samir, any further question?
There's one question which says, are there any recommendations to curtail the use of non-steroidal anti-inflammatory drugs in the current scenario?
Yes, ibuprofen has been found to be injurious, and it has been strictly banned by almost all the recommendations not to be given and not to be used for the patients, those who are having the COVID-19 infection, or those who are more prone or they are nearby to the patient, those who are having the COVID-19 infection. So it should always be taken care. We should take care by the simply paracetamol of the inflammation part.
There is a concern there that because there is a cytokine storm and it is a, you can say, inflammatory condition. So people think that anti-inflammatory, what we call NSAIDs, may be helpful, but in long term, it was found that they are not really helpful. When we say immunomodulation, it is immunomodulation by like tocilizumab, etc., rather than by non-steroidal anti-inflammatory drugs. So you are right. When patient develops fever, paracetamol is safe, but we should avoid all other NSAIDs. Dr. Samir, any other question?
Do we expect any disturbances in electrolytes in diabetic patients with COVID if they are on insulin therapy?
They will be, because of insulin therapy, the chances of hypokalemia will be very high, because once we are using insulin by IV infusion, the chances of hypokalemia, we have to take care of that. That's very important. In addition to that, because of infection and dehydration, hyperglycemia, and diabetic ketoacidosis, that also leads to hypokalemia. We have to monitor potassium regularly.
Dr. Ajmani, you want to add something?
Yes, I do agree that patients who are insulin will need more frequent monitoring. That applies to, in fact, every diabetic, that during sickness, you have to monitor more frequently. You take care of your diet and hydration. And if you find anything amiss, you should contact your doctor or your healthcare team so as to sort out the issues.
So it is the severity of the infection and development of decay and other things. Particularly, they say one should be very careful about fluid intake. Many times they develop dehydration. So proper fluid should be provided to all these diabetic patients, as well as if they develop infection or not. Fluid intake should be properly maintained, and it should be always good to have good amount of fluid from outside. Dr. Samir?
There is one question. It says, why do diabetics tend to have higher levels of biomarkers, or popularly known as cytokine storm, in patients with COVID-19? Why are they more prone?
Dr. Maheshwari?
Yes, cytokine storm is worsening the COVID-19 patient. We all know that, but we also know that all the diabetics have got the level of the inflammations very high, even if they are not having any infection or COVID-19 infection, especially the uncontrolled diabetes. They have got the more secretions of the cytokines. There are the two different kinds of the cytokines, the pro-inflammatory cytokines, anti-inflammatory cytokines. So what exactly happens in the diabetic individuals? More pro-inflammatory cytokines are secreted as it happens in the COVID-19 to cause the COVID-19 storm because of what the solidification of the lung or the consolidation of the lungs takes place and respiratory problems arise. So these things are already existing with the diabetic individuals. That's why diabetic patients are having the higher level of these inflammatory markers instead of the non-diabetic individual. And one more thing I would like to add, as far as the dehydration is concerned, alcohol induces the dehydration. So whenever we are serving or we are taking alcohol orally, we are inducing the dehydration, and it will go against our COVID-19 safety point of view. So we should not be using alcohol at all orally inside of the body. Outside of the body, it is very good, but inside of the body, it should not be used.
Absolutely right. So diabetes, we say, is a inflammatory disease, and
Yes.
diabetes is an inflammatory disease, and there is a very significant immunological, you can say, compromised status in our diabetic patient if they are uncontrolled. And in that scenario, when they get this COVID infection, the chances of their cytokine storms are very high. Dr. Samir?
There's one interesting question. It says that, will insurance cover COVID-19? Suppose a patient with COVID-19 lands up in a hospital or a facility which does not have specific COVID-19 facilities. So would the insurance company take care of it?
Very difficult question. But I think all other things are applicable if a patient is, according to, I think, Government of India, the COVID-19 infection is covered in insurance. This is my general information. But specifically, I am not sure whether hospitalized cost is also taken care of by in a
If
private.
it would not be covered, then insurance company would call it an act of God.
Yeah.
We have the last two questions.
Yeah.
Is there any specific impact of COVID-19 on insulin resistance?
I think we have discussed it in detail.
Dr. Anuj already discussed it, that whenever we develop infections or any inflammation, there is a significant increase in insulin resistance, and these hormones which are secreted like cortisol and growth hormone and glucagon, and all these are anti to insulin. So large amount of these hormones are secreted and they inhibit the action of insulin. And that's why we say that these patients are having huge amount of insulin resistance. And that's why sometimes they require large doses of insulin to control hyperglycemia. I mean,
We have this last question. Uh, the query is, US and UK are supposed to have more infrastructure with respect to any medical facility. So why do we have more mortality there, and why are we tending to have relatively less mortality in the Indian subcontinent?
very smart question. I think I will take it and then we will share it to all the panelists. One of the speaker in one of the earlier webinar told us that Indians are exposed to infection every day. So our immune system is well tuned to have, you can say, respond to this type of infections, and our immune system is always ready. As compared to that, the countries like European countries and USA, where infections are significantly less, their immune system may not be ready. This is one of the theory. Dr. Anuj?
Yes, I agree with you, and this is one of the very important reasons that we are most of the time exposed to various infections to our body already having the strong humoral immunity, and that gets stronger when the any virus and anything enters in our body. It causes the innate immunity also activated by the macrophages and lymphocytes activation, and it leads to the better protection as compared to those people who remains in the conditions where there is no infections the sterile conditions are there, using the mineral water without any infection. So probably they may not be in the habit of tolerance of all these things. Apart from this, I would also give the credit to the lockdown, because of this lockdown in the early stages, the patient could not come out strongly in a big number, so that they could not meet. Even if that congregation in the Delhi would not have occurred, probably our numbers would have been just 50% of what is today. So what we should never be thinking that the steps what we have been taken by our government, our authorities, our ICMR, guidelines authorities, they were quite stronger because of what? In the early days, the ICMR issued a guidelines to start hydroxychloroquine as a prevention, and many people have started that. So all these things affected somewhere or somewhere not, and that's why probably the number of cases and the speed of progression of the illness is not so fast as it is in the Western countries.
Dr. Ajmani, you want to add something?
I
Should I
guess
add, sir?
the less number of patient that we have is probably because of the lockdown only. The point is about the case fatality. Why we have, at least right now, we don't have as much case fatality as we have in US or Europe. That could be because of the host factor. As you said, probably we are more we develop infection more often compared to European or the US population, and we have some kind of cross immunity to these agents. Then maybe our environment, hot and humid, that may also lead to side maybe some effect on the virus and muted disease. Maybe.
Still, you have any idea?
So the type of population also that got infected. The US and UK, the population is more of obese population, the elderly population also. Obese population of more pro-inflammatory markers. You see the
Yes,
leptin,
yes.
other pro-inflammatory markers, the elderly population. That was the reason for high fatality. That is one of the reasons.
Yes,
If you
India
look
is a
at,
comparatively young nation. We
if
are
you look
having
at
more than 72% population less than 40 years, and this has also impacted.
particularly in Italy. If you look
Yes,
into
yes.
Italian fatality, all the people who are above 80 are gone there. So, and you look at the response of the people in USA, they are coming with guns in Michigan and asking governor to open the lockdown. And
Yes.
in spite of lockdown, thousands and thousands of people were there on California beach and all those things. So there they say that it is fascist if you are doing a lockdown. So people have this extreme ideas of lockdown, and that's why I think they are more you can say commercialized country, and they look at everything with the dollar rather than on the life. And that's why, and of course the great president of USA, on one day he speaks something, on another day he speaks something, and he says that you inject is water sanitizers inside you inject all these things. All those things are happening there rather than in India. So we are having a better, you can say, approach, and this lockdown was really helping us. Dr.
Here,
Samir,
I would suggest one experience. I will share one of my experience. In nearby Lucknow, there is a village. In that village, few people came from Delhi. Like when the upsurge has started, the people has started walking to their town, and about 5-6 people came there. The level of awareness was so stronger that those people were not allowed to enter in the village, and they were forced to keep themselves outside of the village, putting up a tent, and they remained there for 14 days or 15 days in that tent, and then they have been allowed. So the level of awareness was so stronger even in the village population. This has actually stopped us to getting so much of worsened condition.
absolutely, you are absolutely right. Samir.
Dr. Sharma, can we have the final closing remarks before which I can give the vote of thanks from your end?
Well, all the distinguished panelists have given their expert opinions. We are, you can say, more wiser now regarding the COVID and its relationship to diabetes, its presentation, its management, and what are the precautions our patient has to take. Thank you very much, all the panelists. Thank you. Over to you, Dr. Sunil.
Thank you very much, Dr. S.K.
Thank you.
Sharma. I think today we had great deliberations on the close link between diabetes and COVID-19. I thank my esteemed panelists, Dr. Anuj Maheshwari, Dr. Sushil Kotru, Dr. A.K. Ajmani, for having given us great insights on patients either who are already with diabetes or at risk of developing diabetes who could be associated with COVID infection. My heartfelt thanks to Dr. S.K. Sharma for navigating the discussion in a manner that our esteemed delegates had simple, lucid take home messages. We
Thank you.
had today 1,478 delegates who have witnessed this webinar from
Great.
across Delhi, Rajasthan, UP, Punjab, Haryana, Jammu and Kashmir, which I would say North Zone. So I thank you all for your precious time, sparing your precious moment, and a special thanks to you all for helping our fellow Indian patients to fight this COVID scare. So let us all remain indoors, remain safe, and may God bless all of us. Thank you and good night.
Thank you.
Thank you. Thank you all.